Colleagues and friends, thank you for joining us for another session of the Virtual Operating Room Formal Neurosurgical Atlas. Our guest today is Dr. Juan Carlos Fernandez Miranda from Stanford University. Juan Carlos does not require any introduction. Not only as being one of my best friends, my incredible collaborator, Juan Carlos is a spectacular surgeon for the skull base and complex intracranial surgery, as well as truly the most outstanding protege of Dr. Rotan. He has truly carried the tradition of Dr. Rotan better than anyone else, and I cannot find anyone who can really claim his legacy, the legacy of Rotan, as much as Juan Carlos can. He is the Chief of Division of Skull Base Surgery at Stanford University. He's also the Director of Neurotrain Center, where a lot of amazing operative neuroanatomical research occur. Obviously, his expertise in skull base surgery and endonasal surgery, more specifically, is second to none. I have been incredibly honored by working with him along the years as one of my dearest colleagues, and I'm so honored to have him with us today talking about resection of chordomas and chondrosarcomas. Juan Carlos, thank you so much, and please proceed.
Thanks, Aaron. It is my pleasure to be again with you and sharing time, trying to contribute to your amazing neurosurgical atlas, the best resource we all have as surgeons. I think from the younger students to the most advanced and experienced surgeons, we rely on your work, Aaron, to continue learning. So thanks again for all these years of friendship and collaboration, and for many more. So today we'll talk about chordomas and chondrosarcomas, and I'm gonna review some of my clinical experience and some technical pearls and surgical anatomy that is key for removing these tumors. These are my conflict of interests. This is my team at Stanford. As you see, I work very closely with my ENT colleagues, and this is very important when you do a skull-based surgery. I have 3 ENT rhinology colleagues. I have actually another 3 lateral skull-based surgeons, and this is so important to develop your good skull-based practice. As Aaron mentioned, I also run the what we call the Neurosurgical Training and Innovation Center at Stanford, where I have the privilege to work with young fellows that want to explore the surgical anatomy and learn, as I did years ago. And it's so stimulating learning from them as they made amazing contributions. And we actually collaborate very closely with Aaron Coyne and the Neurosurgical Atlas to produce the best possible anatomical dissections and operative neurosurgery pearls for all of us to learn. So today we'll talk about clival chordomas and petroclival chondrosarcomas. As many of you know, these 2 tumors have very different biological behavior, and it might be a mistake to put them together, but I do this because they share similar surgical anatomy and technique for the removal. One major difference is that clival chordomas arise from the center, from the notochord remnants in the clival bone here, while petroclival chondrosarcomas arise from the petroclival fissure here and are paramedian. They arise from the foramen lacerum and the fissures that are confluent to the foramen lacerum, and therefore they are paramedian, as you see here. Now, endoscopic endonasal surgery was introduced in, almost 20 years ago for the treatment of chordomas and chondrosarcomas, and the experience was built over the years. And these are the first large clinical series from the Pittsburgh group, the French group, and the Italian group, showing the feasibility of the approach, how it's highly effective, and probably reduces the morbidity, increase efficiency of the operation in comparison with open approaches, and therefore it became a very important approach for clival chordomas and chondrosarcomas. For chordomas in particular, we realized, and this is our paper at University of Pittsburgh, that there is a significant learning curve, and the resection rates and the complication rates are very much related to the experience of the surgical team. You can see here how in the first decade in Pittsburgh, or the first 5 years, the resection rate was about 36%, while in the following years, it jumped to almost 90%. This is for primary chordomas, first operation, while the complications remain the same, approximately. And if we look at the experience and the learning curve, you can see how there is a continuous increase in the resection rates that we are able to achieve as we increase our experience and we are moving along the learning curve. When we look at a more recent series from my experience with the team in Pittsburgh, we look at 106 patients, 151 operations. You see that many of them were previously treated, and that's unfortunately common with clavicle chordomas as they tend to recur. But you can see how the gross total resection for recurrent tumors was significantly lower than for primary tumors. But you're also we're going to see how this depends on a number of factors, and among them are, as you see, years of experience of the surgeon. Even more so for recurrent tumors means you need more experience when the tumors are more complex or recurrent. This is something obvious, but there are other factors like previous multiple surgeries, and of course, when it's a larger tumor that involves at least 2/3 of the clivus, and especially the lower third involvement was a significant risk for not so good resection rates. It was more difficult. The same involvement of the crinocervical junction was another factor that influenced resection rates. But we can see how the learning curve also applied very much so for recurrent tumors. The resection rates, complete resection rate, gross resection rate, increased from 27 to 53 to 56 to 83%. And these are my middle years in Pittsburgh. We were doing many chordomas and improving our resection rates as we went along. And I think the reason for this improvement is not only the experience, but also more knowledge that we acquire by working in the lab and learning the anatomy. And that's what I want to share with you today. Why is this so important? Because resection rate on chordomas makes a difference and has a significant impact on the outcome. And you see here the lines for progression-free survival. When you have a gross total resection, is very different than when you have a subtotal or a partial resection. And this remains true also for recurrent tumors, where gross total resection rate is sometimes possible and actually often possible, and also involves a better prognosis. Therefore, there is a steep learning curve for clavicle chordoma surgery. This is definitely an operation that should not be done by surgeons without enough experience. It should be done at centers, multidisciplinary, with the proper training. This is what is going to make a definite impact in the quality and outcome of these patients. Another thing we also sort of discovered at University of Pittsburgh at that time is that, of course, we all know all chordomas are different. And we realized, and this is a work of one of our previous fellows, now younger faculty, Dr. Senonos, excellent work, where we realized that you can stratify in 3 different categories clavicle chordomas based on the Ki-67 index. And you can see here the different groups. And then on fish studies and the existence of this deletion or this other one or this other abnormality. And the percentage of this would really influence the survival in these groups. So we categorize group A, B, and C from low, medium, and high risk chordomas. And you can see how the curves are so dramatically different. So the biological behavior of these chordomas is different. And we can actually do these studies now and sort of stratify your patient into 3 different groups. And that actually is influencing the way I counsel my patients. For example, if I have a patient where I've done a complete tumor resection, And I'm very happy because I even got some margins. It's a tumor that is relatively focal, and I can do a very good clean resection. And the patient is in the group A, where there is a low KS is lower than 3%, and we have low rate of these fish abnormalities. In this case, I might actually recommend observation and no radiation, and leave radiation as a possible tool in the future if there is a recurrence. But this group of patients has the lowest risk for recurrence, and therefore radiation might not make sense. I know this is a bit controversial because many experts in the field recommend radiation for all patients across the board. Now, we have the second group with intermediate prognosis, and in this one, if you get a gross total resection, still, usually you recommend radiation because there is some concern for higher risk of recurrence. If there is incomplete resection, you should try to remove it completely. Now, if you think that's too high morbidity, then radiation is definitely indicated. I always counsel patients, if you had another operation and there is residual tumor, please get a second opinion with an experienced surgeon or surgical team to see if that residual tumor can be removed relatively safely. But not all chordomas can be completely removed, so it's not always possible. But often, it's the experience of the surgeon that determines the completeness of resection. Unfortunately, we have the group C that has the worst prognosis with really unfavorable features, as you see here. And in these ones, always radiation. And actually, there should be a consideration for further surgery, some in new therapies like immunotherapy trials, etc. These are behaving almost like sarcomas, very aggressive and malignant tumors, unfortunately. Now, just a word on chondrosarcomas. They are different animals, as we said. The majority of them are more indolent and not as aggressive as chordomas, although we see some bad players occasionally, of course. Our initial experience, and this is a bit outdated, you see 35 patients, 42 plus 6, 48 operations. The extent of resection was a bit lower for chondrosarcomas, but that was also on purpose, and it's because sometimes these tumors encase the choroidal, encase cranial nerves, and if you think you are dealing with a lower, a tumor with lower morbidity, perhaps some residual tumor is more acceptable, although we always try to achieve a complete tumor resection in chondrosarcoma patients. Now, after that introduction about our surgical experience, especially during my time at the University of Pittsburgh and now into Stanford University, I want to share with you what I think is very important surgical anatomy and technique that really, I believe, was key and instrumental in improving our resection rates and decreasing, or at least maintaining, an acceptable risk of complications. We developed this classification of the clival and petroclival region in 3 levels, and this was following Professor Rotton's rule of 3 of the posterior fossa that many of you know. We developed this rule of 3 of the clival region in upper, middle, and inferior clival region. And you see the upper clival region entails mostly the dorsum sella down to this bony prominence I'm going to explain later to you. This bony prominence is located right here. And it's this little slope that touches the petroclival fissure and the petrous apex. This is called the Petrossal Process of the sphenoid bone. And it's actually where the 6th nerve runs to enter the Drellus canal. So that is our lower limit of the upper clivus. And if you look at it on the sagittal view endonasally, it correlates with the floor of the sella right here. So we call this area the sellar clivus because it entails the sella, the dorsum sella, the posterior clinates. And the pituitary is in front of us. So we need to deal with the pituitary gland in this upper clivus, as I'll show you in a few minutes. Then we have the middle clival region right here. Goes from Drellus canal down to the beginning of the jugular foramen here. And it is the part that is facing the petrous apex on both sides. And usually for open approach, you use a transpetrosal approach to get here. But now working endonasally, you have a direct access to this, what we call a sphenoidal clivus, or the sphenoid portion of the clivus, because this is mostly done by the sphenoid bone. It goes from the floor of the sella down to the level of the floor of the sphenoid sinus right here, where the choana starts, where the pharyngobasilar fascia comes here and attaches to the bone. So the mid clivus is this portion of the sphenoid. If you drill it, you get access to the prepontine system, where often chordomas extend. And finally, we have the lower clivus. The lower clivus includes from the foramen magnum and condyles and jugular tubercle up to jugular foramen here. And this lower part of the clivus includes the craniocervical junction. And as we said, is one of the most tricky areas to work because the tumor can actually involve the C1 junction and make the resection more difficult and more morbidity because of the craniocervical instability that can be caused by this. Now, in the upper clivus, as we said, is the sellar clivus from the Petrossal Process to the posterior clinoids and dorsum sella. We have the pituitary in our way to get to the dorsum clivus. To get here, we have the pituitary. So we need to learn how to do mobilization of the pituitary gland. And this was an original description by Amin Kassam, one of the most original technical nuances. I was fascinated when I saw him doing it. What a beautiful approach to remove the pituitary gland off the sella so you can get access to the dorsum sella behind. This technique was described initially as an extradural approach where you dissect the dura of the dorsum sella so you can get access to the bone here and to the beginning of the posterior clinoid here. The problem with this extradural approach is that it's quite limited because the dura of the anterior wall of the cavernous sinus right here is going to be preventing the displacement, superior displacement of the pituitary gland, and therefore is limited. Now, that's why Dr. Kassam developed this technique where he would open the dura and mobilize the pituitary gland out of the sella, put the pituitary gland out up here into the interpeduncular, into the suprasellar system, into the suprasellar system, and then gives access to the dorsum sella and posterior clinoid here. You can remove all of this, and you can open this and get a parallel view of the interpeduncular system. This is a technique that is highly effective, and I like to employ it, especially with intrinsic tumors like cranopharyngiomas that have a lot of retroclival extension. And I do it mostly again for intrinsic tumors where the risk of pituitary dysfunction is significant already, because I worry about this mobilization of the pituitary gland causing pituitary dysfunction. Now, some years later, we describe this transcavernous posterior clinoidectomy, or what we call the interdural approach to the posterior clinoid or the upper clivus. Interdural because we use the layers of the cavernous sinus to get access to the posterior clinoid and before. And this is the original technique we described. As you remember, the pituitary gland has an outer layer of dura, and then there is an inner layer of dura. And this bifurcation here is what forms the cavity of the cavernous sinus. So we open it right here, and as this diagram shows, we mobilize the medial wall. So the pituitary gland is still protected by that medial wall, and we can have direct access here to the posterior clinoid, so we can drill it. In our way, we are working between the carotid on one side and the pituitary gland, medial wall of the cavernous sinus on the other side. And here you can see how this technique is the equivalent of the Dolenc approach. Dolenc described this transcavernous transsellar approach to get to basilar tip aneurysms to be able to remove the posterior clinoid. And this is the other way. This is a transsellar transcavernous approach. It's the opposite to get to the same area. These are the different steps of this approach. You see the two layers. This is the cavernous sinus starting right here. Now, what we're going to do is open the anterior wall. We're going to open this anterior wall right here. So then the medial wall can be mobilized, and then we work between the medial wall and the carotid artery here, and gives us access directly to the posterior clinoid right here. So we can remove it with direct visualization. The posterior clinoid is often quite tall, and it has very severe adhesions of ligaments, the petroclinoidal ligaments and posterior petroclinoidal ligament. And this ligament has to be dissected, and that is difficult unless you have good access, as this transcavernous route provides. Very important we describe how in this route to the posterior clinoid, you have this artery, which is the inferior hypophyseal artery. So if you are not careful in this route through the cavernous sinus, you can potentially abulge this artery and start seeing arterial bleeding, and it can turn really bad if this avulsion is proximal from the wall of the carotid. So you always need to be very careful, and I like to coagulate this artery up front so I don't have to fear, a hole in the carotid artery wall. Once you take the clinoid, you have this excellent exposure. You are now seeing the oculomotor triangle laterally, the posterior wall of the cavernous sinus here, and you could open the dura along this line if needed for tumor that is extending intradurally. And as you do so, you can see the third nerve that is entering the oculomotor triangle right here. And this is your intercranial ligament. This is the posterior communicating artery. You get phenomenal access to this lateral recess of the interpeduncular system. So as we learn more and more the anatomy of this area, we realize that as we go through the cavernous sinus, we encounter often these ligaments, and we call these deep paracetral ligaments. These ligaments are attachments from the medial wall of the cavernous sinus to the carotid and to the other walls of the cavernous sinus. And we describe a number of them. The most important one is this one here. This is the so-called carotidoclinoidal ligament, and is the same as the proximal dural ring, the ventral aspect of the proximal dural ring. This ligament that you can see here comes on the middle wall, and then it goes on front of the carotid, forming like a collar around it, that's the proximal ring, and then goes behind the carotid, like this, and like this, to meet the anterior clinoid process, the tip of the anterior clinoid on the other side. This membrane, carotidoclinoidal ligament, separates the cavernous sinus cavity, which is all this is cavernous sinus here, from this clinoidal space up here. And this clinoidal space is a much narrower space, but it's important to understand this anatomy. When we are working through the cavernous sinus to get to the posterior clinoid, usually you don't have to cut this CCL. You have enough access to get the posterior clinoid just behind. But there are occasions where you have tumor extending up and you need to cut through the ligament, even through the diaphragm, to join your retrocellular exposure here, your retrocellular exposure right here, with the supracellular exposure. And you can do this, what we call an extended transcavenous approach, to get to the interpeduncular system and supracellular systems. Now, we also describe, very important, we said the CCL, but we also describe the, this ligament here, the inferior paracetral ligament. And this one is very important. We just cut it from here. It's very important because this ligament is the first one you encounter when you open the anterior wall of the cavernous sinus. And it's the one that you need to cut first to start making your way between the medial wall and the carotid. If you cut this ligament, you can start separating both, mobilize the carotid, mobilize the pituitary gland, and just get your access directly into the posterior clinoid here behind. Of course, again, remember the inferior hypophyseal artery is in your way and has to be sacrificed. Sometimes you can actually dissect or mobilize it, but I don't hesitate to sacrificing this artery. This anatomy of the middle wall and ligaments is so relevant for transcavernous approach. This is the paper we published about this. This is very relevant about pituitary surgery too. We talk about this in a different webinar, but it's also very relevant, as you see today, on working through the cavernous sinus to get to the posterior clinoids. So I'm going to show you a couple of examples of doing posterior clinoidectomies using this technique. This is a 14-year-old patient I did here at Stanford, and approximately 2 years ago. And they had done first an orbitozygomatic approach for what they thought was a brainstem lesion. They didn't realize this actually was coming from the clivus. You can see this is post-op, and there is tumor left in the posterior clinoids, dorsum sella, and even in the brainstem right here. So this whole dorsum sella has tumor on it. Now, as we said before, what do we do with this? Do we just go for radiation in a 14-year-old, or do we want to do a complete resection? So my recommendation, of course, was complete resection. So we went for it. And here you will see this is where we have done our opening of the sphenoid sinus. The cella has been drilled. I drilled the whole middle clivus. So I've cleaned all the area, and you see there's the dorsum cella, and I cannot remove it, and it has tumor inside. So I'm using a Doppler ultrasound to map the carotid artery, and I open directly through the anterior wall of the cavernous sinus. I know the carotid is a bit more lateral. Once you open up in the anterior wall, you of course get your venous bleeding. And this is the hemostatic agent that we use. It's highly effective. You can inject it. We are using a special suction tube to inject it. This is the right angle knife that is so important to open this dura. That's the inferior parasitic ligament. And I can transect this ligament. You see, this instrument is key because it has a blunt tip and an upper surface that is that is sharp. And now I identify the inferior hypophyseal artery. Once I cut the inferior hypophyseal artery, I can separate the carotid more, and I can get excellent access to the posterior clinoid. And see how big this posterior clinoid is. And it's very difficult to remove without opening the cavernous sinus. Now I'm removing the posterior clinoid on the other side. In this side, I did not open the cavernous sinus wall because I had enough space, and I could bring that posterior clinoid down. So in this case, I opened one cavernous sinus to remove this posterior clinoid. And this way, we completed our resection of the posterior clinoids and dorsum cella. I'll show you more of that case later, but I wanted just to show you the posterior clinoid portion. Now, this is another case. A recent case I did, 74-year-old patient, presents just with nasal obstruction. You see a panclival chordoma, mostly extradural, with some interdural extension, as you will see. But in this one, there is not so clear invasion of the posterior clinoids, but the tumor is displacing the pituitary gland up. And I worry the posterior clinoids are going to be involved. So I'm going to go after them. I'm going to take them. You see, again, the right angle knife, opening the anterior wall of the cavernous sinus. Inferior parasitic ligament is almost always there. Once I cut the ligament, I can start separating artery from middle wall. That is a nice view of the inferior hypophyseal artery. I dissect it, coagulate, transect. After I do so, I have much more space to safely remove the posterior clinoid. You see, this posterior clinoid was smaller. Taking the dorsum cella, and I'm going to open in the other side because it's big. I don't have enough access. Same operation, Doppler, right angle knife, identify the medial wall, find the inferior parasitic ligament, another beautiful example. Look at that very robust ligament. I cut it with this right angle knife we designed. And then we have our inferior hypophyseal artery. In this case, we didn't find it. There was no inferior hypophyseal artery on this side. But I have excellent access to get this whole posterior clinoid, which is very robust, and it seems to have tumor inside. Believe it or not, there was tumor in this clinoid, and we can remove it completely. Look at that ring, osseous ring. The posterior clinoid sometimes forms an osseous ring with anterior clinoid, and you have to break it so you can remove it completely. And then we're taking the dura, but we finish our bony portion of the resection for this case by taking those posterior clinoids. Now, when we started doing this technique, we were wondering if by going to the cavernous sinus and mobilizing the gland and coagulating inferior hypophyseal artery, we would have any increased risk of pituitary dysfunction, and the answer was no. All of our initial a dozen patients we did initially, none of them had any pituitary dysfunction. This include both unilateral and bilateral sacrifice, but most of them was unilateral. Years later, we review, as we evolve and apply this technique more and more often, we reviewed 20 consecutive patients where we did this bilaterally in all of them. All of them had bilateral posterior clinoidectomy, bilateral sacrifice to the inferior hypophyseal artery, and only 2 patients got DI, 1 patient got hypercortisolism. I do believe those are not related to the sacrifice of the arteries, but of manipulation of the pituitary gland in some of these very large chordomas or skull-based lesions. So borderline, we believe that the inferior hypophyseal artery can be sacrificed safely because the superior hypophyseal artery will compensate. As long as you preserve the superior hypophyseal artery, the perfusion of the pituitary gland and stalk and posterior lobe would be preserved. Now, can you always do this transcavenous approach? No, you cannot. This is a case I did while at Pittsburgh, and in this case, you can see this patient has kissing carotids. residual tumor left at the posterior dorsum sella, posterior clinoids. But if you look at that, those carotids are kissing, which means I'm not going to be able to develop a corridor between the pituitary gland and the carotid. It's going to be really difficult. And get to that posterior clinoids and dorsum sella is going to be a challenge. So what do we do in this case? Do we give up? Do we just go for radiation? Do we try to remove the tumor? So what I did is I modified the technique. You can see the carotids are here and here. There is all a few millimeters only in between. So what I did is I opened the dura in the midline. And if you realize, the two carotids are actually tethered by the dura on the floor of the sella. So if I coagulate and cut the floor of the sella all the way back to the dorsum sella, I'm going to be able to get more space, separate those carotids. So I'm not going through the cavernous sinus. I'm just going, it's like a combination of the intra and extradural, cutting through the floor, exposing the bottom of the pituitary gland, allows me to separate both cavernous sinuses. And then I can get access that way to the posterior clinoids. I know some of my colleagues, for example, in Japan, use this technique routinely for all their cases. I prefer to open the cavernous sinus directly when I can, because I have better control and I believe, in my opinion, better visualization. But the technique can be modified according to the anatomy of each individual patient. In this case, we had to go through the floor of the sella, cutting the dura to get to the posterior clinoids. And you can. So now let's move to the mid-petroclival region. As we said, this is an area where endonasal has made dramatic changes, because in the past, transpetrossal approaches were the only option to really do an effective operation in this area. But now endonasal provides just such a direct access to this region. In this area, we need to understand very well the anatomy of the cranial nerve 6. Of course, as we said, we go to the clivus, we drill the clivus, we get access to the prepontine cistern, where we have the basilar artery and the perforating branches, but the sixth nerve is on each side. This is the sternal segment, this is the interdural segment that goes into the Dorellos canal, goes behind and lateral to the carotid to get into the cavernous sinus. I'm going to show you, again, let me re-emphasize the anatomy. So the sixth nerve has a cisternal segment right here. Here starts the interdural segment, follows the same trajectory, same direction, goes up. And then, as I'm going to show you, it bends on top of this bone right here, which is the Petrossal process of the sphenoid bone that continues with the petrous apex. And here is where the sixth nerve enters, changes its direction. It becomes almost horizontal. It goes behind the carotid, then lateral to the carotid right here, and then goes up into the inferior compartment of the cavernous sinus. Okay, so let's look at this case. This is a nice case of a clival chordoma that is centered in the mid-clivus. You see, just below the sella, there is an extradural component and an intradural component that is compressing the basilar artery and the pons. You see, what I do in this case is, instead of going to the tumor and start sucking tumor out, I really spend a lot of time going around the tumor, drilling all the bone around it, from the foramen lacerum, as I explained later, up to the sella, to both carotids. And only when I have the tumor well surrounded, I go into the tumor and I do intracapsular debulking. So we cannot do en bloc resection in clival chordomas for the most part, but we can do an equivalent of en bloc resection, which means surrounding the tumor completely, getting clean margins, debulking it inside, and then progressively going in the outside. And that's the best way to get a clean, methodical resection in these patients. So now we got all the way to the dura, and I leave in the interdural component. But you see, at this point, I have exposed both carotids completely from the foramen lacerum to the sella. There is no bone left of the clivus. I've taken, not in this case, I didn't take posterior clivus. There was no need. There is no invasion whatsoever, but up to the dorsum sella. Now we go into the interdural portion. And we're opening the dura. You see the tumor invading there. You see the basilar artery displaced to this side. If the basilar artery is displaced to this side, I worry less about the left side sixth nerve pulse, sixth nerve. I worry about the right one, because here the basilar is primarily protecting the sixth nerve. These tumors are usually soft, but sometimes are partially calcified, and they can be quite adherent. But in general, if this is the first operation, the tumors can be nicely resected. The problem is recurrent tumors, radiated tumors, the planes can be really unfavorable. But in this case, if you do a careful dissection, if you take your time, you're meticulous, then you can do excellent resection. That is the tumor being peeled off the ICA, anterior inferior cerebellar artery, and we can finally remove the tumor completely. Always in this area, we worry about the sixth nerve, and in this particular case, the right sixth nerve. Always very careful with seeding these tumors. Truly, the risk of seeding is actually very low. I've only seen it with tumors that are highly aggressive in the grade C category. You can see here sixth nerve right here, and we're going to trim the dura close to the Relos canal. You can see the third nerve superiorly. I'm looking for the arachnoid. Sometimes there are tumor cells trapped in the arachnoid, so I'm opening the arachnoid, making sure there is no tumor left anywhere. And I'm going to send dural margins. I like to send superior, lateral, medial, inferior dural margins, even sometimes arachnoid margins, to make sure I'm not leaving any tumor behind. I really think these tumors need to be treated like a cancer. This is a type of bone cancer, it's a type of bone or sarcoma, and we need to achieve complete tumor resection. Now, I showed you this case previously, and I showed you how we took the dorsum cell and posterior canals, but there's also brainstem invasion. So what do we do in this case with brainstem invasion? And this, as I said, you saw a case that we nicely dissected off, but this case is recurrent. There was not recurrent, it's recurrent, there is regrowth, but also previous operation. So the planes are not so favorable. And you see I'm in the brainstem, I have to dissect and work between these perforating branches, pontine perforating branches. You can do this very carefully. And then thankfully the tumor remains soft, so I can gradually debulk it, working within the tumor cavity in the pons, and using for this case neuromonitoring. I didn't mention before, but I routinely use cranial nerve monitoring for these cases, especially for nerve 6, which is the one at risk most often. But in this particular case, going into the brainstem, I would also use motor evoked potentials, and those remain stable throughout all of resection. You see how the instruments we're using are microdissectors, similar to Roton, but especially designed for endonasal endoscopic surgery. We barely use ring curettes because this is more microsurgery than anything else. And here we're using the two sections to look for interresidual tumor. And again, I'm going to remove that last layer of tissue, and I'm going to send it to the pathologist. I want to hear from them that this is negative for tumor, and then I'll be ready for closing. So remove everything, very clean resection, and this patient did great. We'll talk about reconstruction later, but this is multi-layer always, fasciolata, fat graft, and a large extended septal flap that covers everything is the best guarantee for success in these cases. And this is the post-op, intact patient, no complications, complete resection. Now, as we said, understanding the sixth nerve is so important, and especially understanding it as it gets into the Relos canal. That is the most difficult area right here. And what we've learned is the Petrossal process of the sphenoid bone is a key landmark, and the dural fold that covers it. You see this dura right here. And this is equally important for chordomas and for chondrosarcomas. Gruber's ligament is less relevant because this is Gruber's ligament. It's behind the sixth nerve. So I find Gruber's ligament after I find the sixth nerve usually. But I can find the Petrossal process before I can find the sixth nerve. And therefore, that is the real good landmark I use in surgery. So what I do is I expose the carotid completely, and then with my dissector, I feel this bony slope right here. When I feel that bony slope of the Petrossal process, I know the sixth nerve is going to be just behind, just above that dural fold. I then usually use my stimulator to confirm, and I use that in surgery all the time. I'm going to show you now how we work around the sixth nerve for tumors that are more invasive. This tumor extends more laterally. You see here, the sixth nerve can be seen actually right here on the Fiesta sequence. And we lost it here. So it's somewhere there. So it's very difficult. So in this case, I'm working in the interdural space. I'm right within the Dorellos canal. This is the sixth nerve right here. This is the sixth nerve right there. And this is the Petrossal process. So a trick I've learned is if you remove the Petrossal process, the sixth nerve becomes more free and it tolerates manipulation better. You can see here the sixth nerve intradural, cisternal segment. I can stimulate and I can trim the dura up to its entrance in the Dorellos canal. Then I'm working in between the two layers of dura, so I can trim both under direct visualization of the sixth nerve trajectory. This dura is all involved, so that's why I'm removing it. And then I'm going to keep following the sixth nerve and trimming the dura parallel to the nerve. And I use that blue tool, that's my stimulator. And I use it to track the nerve and to see if the nerve is tolerating well the dissection we are doing. Now, this is the very important anatomy I was trying to explain, which is this Petrossal process right here. You can very well identify this in surgery, and the sixth nerve runs just in there. In this dissection, you can see this is the Petrossal process and the petrous apex. Petrossal process and the petrous apex. One of our fellows in the lab, Julius, was studying this carefully and showed me how actually it's not always the Petrossal process. It is here because this is the pituitary fissure, but sometimes the Petrossal process is very short. And actually what you have here is the petrous apex. So the sixth nerve could be on top of each of those structures. But regardless, what really matters is identifying this slope, because this slope behind the carotid canal is what tells you where is the sixth nerve. So when you come in the nasal, you come this way. You find this slope, here is the sixth nerve. Okay, it's always like this. It's a very, very reliable landmark. And here is in surgery. Going endonasal, this is our dissection. This is the cella right here with the pituitary gland. This is the clinoidal and cavernous carotid. This coming down. And this is the carotid coming up. And you see I'm displacing the carotid in this direction laterally. And then you can see the bone right here. That is the Petrossal process. And the sixth nerve is right here. And if I remove this bone, and sometimes this bone you can remove and block, and that completes your clivectomy, you remove this bone, the sixth nerve has no bone underneath now. And this sixth nerve is now more free. And you can do better dissection. You have tumor around the sixth nerve, and you have to work above and below the sixth nerve. Having no bone underneath is ideal. And patients will tolerate that better. So I'm going to show you an example. Now, this is an example of a chondrosarcoma. These tumors are even more often involved in the sixth nerve because, as we said, they have a location that is more paramedian on the petrous apex. This tumor goes, from the foramen lacerum that is expanded here down into the jugular foramen, up through the petroclavian fissure into the petrous apex and cavernous sinus. Go to the next, please, Luke. So we've done a lot of work here, Transcavenous approach, remove a lot of tumor, but I'm going to show you how we find the sixth nerve. You see this bone we're removing here is what is left of the clivus. That is the Petrossal process of the sphenoid bone right here, clearly involved by tumor. And the sixth nerve is going to be just above that. You see that dural fold I'm cutting right here. That's the dural fold that covers the Petrossal process. This here is your sixth nerve. You can see it clearly now, the sixth nerve here, and how we were able to identify it early in our operation using these very reliable landmarks. Now, I'm going to move a bit more into some important anatomy, and this is the anatomy of the transpterygoid approach. And this is so important for mid-clavicle chordomas and inferior clavicle chordomas. So first, as you know, this is the sphenoid bone, and the sphenoid bone has the body of the sphenoid here, and then we have the pterygoids. We have a medial plate, a lateral plate, median, V2. So in front of the pterygoid, we have this bone, the palatine bone, and they form together the pterygopalatine fossa in between, right? So the pterygoid here, vertical plate and horizontal plate. And then this pterygoid bone has two processes that are very important to understand. This process here is the sphenoid process of the palatine bone right here. Sphenoid because it touches the sphenoid floor. This process here is the orbital process because it forms a small part of the floor of the orbit. In between, we have this foramen, which is the sphenopalatine foramen right here. It's the foramen that is used by the sphenopalatine artery to go from the pterygopalatine fossa into the nasal cavity. Okay, so understanding this configuration is key. And also, look where is Vidian canal. So Vidian canal is inside the pterygopalatine fossa. If you want to find Vidian, you need to open the pterygopalatine fossa. You need to remove the sphenoid process. You need to remove the orbital process, and then you can find Vidian nerve. This is a recurrent question. How do you find Vidian nerve in an operation? It's not with image guidance. It's by using anatomy. And this is the key anatomy to understand it. So here we see again the palatine bone. This is the sphenoid process. The sphenoid process covers an artery, which is this one right here. This very important artery is the palatosphenoidal artery. It goes from the pterygopalatine fossa down into the nasopharynx. It's covered by this palatine bone, sphenoid process. If you remove the sphenoid process, you can see and identify the artery. Once you identify the artery, you can coagulate it and transect it, and you can move it in a subperiosteal fashion, and you will find the Vidian nerve. That is the best way to find the Vidian nerve. Once you find the Vidian nerve, you can start drilling the pterygoid above the Vidian and below Vidian as you get closer to the foramen lacerum. As you get closer to the foramen lacerum, you want to stay on the lower aspect of Vidian canal, as Dr. Kassam described many years ago, just to be safe and not get into the carotid. Something that we've learned that is very important landmark these days is the pterygosphenoidal fissure. This pterygosphenoidal fissure is located right here, and is the fissure between the sphenoid sinus floor and the pterygoid bone. Still is not the clival bone. The clival bone is a bit more posterior than this fissure. So the correct name for this is the pterygosphenoidal fissure. You know, the sphenoid bone is one single bone, but they have different embryological origins. The pterygoid comes from one place, the sphenoid body comes from other. There is a junction in between them, and that junction is the pterygosphenoidal fissure, which actually you can see very well in children. When I do surgery, I've seen this like being like cartilage, pterygosphenoidal fissure right here. So the importance of this fissure is that if you drill the pterygoid lateral to the fissure, you drill the sphenoid floor medial to the fissure, you follow this fibrous tissue, and it's going to confluence, it's going to have a confluence directly, going to take you directly into the foramen lacerum. And to me, this is the safest way to expose the foramen lacerum. You know, the exposure of the foramen lacerum, it really is difficult. And it took me years to master this exposure, but it's so important because it's the most inferior aspect of your exposure and your carotid canal. And you want to scrutinize the whole carotid in many of these cases. That's why it's so relevant. So the foramen lacerum is this opening here, is this gap that is in between the sphenoid bone, the petrous bone, and the clival bone. So three bones come together, they leave a gap, that is the foramen lacerum. Now, at the same time, it's formed by three different fissures. So there is the pterygosphenoidal fissure, the petroclival fissure, the petrosphenoidal fissure. These three fissures come together right here in the foramen lacerum, and that is what it is. The Vidian canal takes you there, the pterygosphenoidal fissure takes you there. These are your two landmarks, pterygosphenoidal fissure and Vidian. For those with more interest, you know, we describe this anatomy in great detail in this paper. This is difficult anatomy to understand, but I'm going to try to give you the most important tips that I think can come up of this work. We found out that between the pterygosphenoidal fissure, which you can always see in a CT scan, you can see it right here, and the Vidian canal right here, there is usually a 45-degree angle. And that is helpful because you can follow both structures as they come together, as they converge into the foramen lacerum. The foramen lacerum, as you know, is what we call a ventral scalvis crossroad. From the foramen lacerum, you can go so many different places. So you expose this area right here and the carotid right here. You have the most difficult part of the exposure completed. Then you can go up into Meckel's cave, middle fossa, up a lateral, I mean. You can go directly up into the cavernous sinus. You can go behind the carotid into the petrous apex and petrocaudal fissure. You can go low and a bit medial into the jugular tubercle. You can go low and lateral towards the inferior petrocaudal fissure and jugular foramen. So there are so many areas around, but the starting point is the foramen lacerum exposure. That's why I put so much emphasis in studying this very carefully. As I mentioned, Vidian canal and pterygospinal fissure form a 45-degree angle. You can see this in your bone specimens, and you can see this is the skull has been flipped over. We're looking at the base of the skull from behind. Okay, so this is the choana right here, the choana. That will be the front. This is the back. So you see this is the pterygoid, medial plate, lateral plate, floor of the sphenoid sinus. You see this is cleval bone. It starts here, cleval bone. This is a sphenoid bone right here. All this. And then you can see how there is this line right here between the pterygoid and between the sphenoid. And this takes you directly into the foramen lacerum right here. And you see this opening, that little hole right here, that little hole right here, that is the opening of the Vidian canal. You see the 45-degree angle. And at the confluence of both, we have this bony prominence right here that is there. And when I was writing this paper, I was thinking, how do we call this? What is this? And I look into it, and Gray's Anatomy actually had described this many years ago, and this is called the pterygoid tubercle. Of course, they didn't know the surgical relevance of this pterygoid tubercle. Now we have the surgical relevance, but that is the name of this bony prominence between Vidian canal and pterygospinatal fissure. This is the pterygoid tubercle. So if you remove the pterygoid tubercle, you get access directly into the foramen lacerum. So more dissections showing you these landmarks. I'm just gonna pass through this, but this is now looking from the front, and this is an open dissection. You see this is rosum, this is eustachian tube. So this is the choana right here, choana. The sphenoid sinus will be here. And now we're seeing the carotid going down. And again, this was in Vidian nerve, and we're seeing the pterygospinatal fissure. They form this triangle, which we use as our landmark. If you remove all the bone here, and the apex of the triangle here is a pterygoid tubercle, you remove it, this is where the pterygoid tubercle was, right here. And it gives you access directly into the jugular, into the foramen lacerum. Inferior aspect of the foramen lacerum, if the pterygoid tubercle sits, is the safest entry zone to the foramen lacerum, in my opinion. And that's what I use in my operations very often. Okay. Another example of the relevance of the pterygospinatal fissure, not only for exposure, but also if you need to access the inferior aspect of the petrous apex, you need to transect the pterygospinatal fissure so you can access the bone behind in this area. And look, please play this video as I'll show you in this dissection. As we transect this tissue, we can get access to this whole corridor here, which is the inferior petrous apex. What you can see here is the inferior petrossal sinus right there. So this is the jugular foramen, is the ventral aspect of the jugular foramen. So this is our avenue into the jugular foramen. And this gives you the exposure from the sixth nerve here, the top of the petrous apex, the whole petrous apex down to the level of the jugular foramen. And if you could go as lateral here as the anterior aspect of the internal acoustic canal. So you can get a lot of the petrous apex exposed and tumor removed from this area by doing this, what we call this Trans-Lacerum Approach, which means we cut the foramen lacerum tissue right here, which is no other than the pterygosphenoidal fissure. And that allows us to swing the carotid laterally gently and gain some access to this petrous apex. Extremely effective technique, very much so for chondrosarcomas and for some chordomas. So I'm going to show you an example of all this important anatomy I just described with this chondrosarcoma I did recently. This young lady, international patient that came from South America to have this removed with me, referred by a kind surgeon in her country. You see the carotid is being displaced laterally. So our first exposure is going to be finding the median nerve. So that is the vomer, that's the choana. This is the sphenoid process of the palatine bone that I'm removing. This is the palatosphenoidal artery and palatovomeral artery. There are sometimes two arteries here. So once we coagulate this first the palatovomeral artery, then the palatosphenoidal artery, we can mobilize the pterygopalatine fossa contents laterally. I didn't show it, but the first step here is open the medial wall of the maxillary sinus and remove the posterior wall to access the pterygopalatine fossa. You see, we are coagulating the palatosphenoidal and palatovomeral artery. That is what is anchoring the pterygopalatine fossa. You can see nicely the palatosphenoidal being displaced down into the nasopharynx. Now you have the pterygoid, and now here is my Vidian canal right there. So easy, right here. Okay, the arteries I coagulated and identified are the key for finding Vidian nerve. Once I have the Vidian nerve exposed, now I drill the sphenoid sinus floor all the way to Vidian. And I keep drilling the sphenoid sinus floor until I find the beginning, as you see right here, of the pterygosphenoidal fissure. You see tissue starting going there, right here. Pterygosphenoidal fissure, Vidian, and I'm going to follow them towards the foramen lacerum. In this case, I'm coagulating and cutting Vidian. When I really have to expose the foramen lacerum well, I cut the Vidian nerve, because then I can mobilize pterygopalatine fossa more, I can drill the sphenoid, and I can get so much more access. If I just need to expose the foramen lacerum, I don't need it, but I have to go and work around it. I need to really sacrifice the Vidian nerve, which has actually no significant functional consequences. That's a middle clinoid that I just removed, quite prominent. So I'm going to expose the carotid from the cavernous sinus and clinoidal segment down to the foramen lacerum. That is abnormal bone. And you can see my pterygosphenoidal fissure down here. Vidian, pterygosphenoidal fissure, coming together all the way to the carotid. In this case, these landmarks were very important because the carotid was very displaced. So it's difficult to identify the carotid because it's so distorted. But I used this landmark to find it. And I cut the pterygosphenoidal fissure so I can get access to tumor that you see right there that is extending inferiorly into the petrous apex and towards the jugular foramen. Once this is done, and once I have the foramen lacerum exposed, the rest is actually quite easy. Just with a keratine, you can completely expose the carotid and all the tumor invading the carotid canal. And now I'm cleaning all the bone around it, getting a clean margin of tumor. That's my cartouche stimulator. I'm finding the sixth nerve. This is a stitch I put in the pterygopalatine fossa, simply so I can have a bit more of space. Then I just get it with a mosquito outside. And this again, look at my pterygosphenoidal fissure, how I can use it to follow and get into the carotid canal at the level of the foramen lacerum. Doppler ultrasound, always key. That was the supraorbital fissure below V2. And now taking all the tumor. Now I'm starting to see the carotid in the cavernous sinus. You will see it shortly. That's cavernous sinus wall and carotid. The carotid has been displaced, and the cavernous sinus in this case was not invaded, which is an excellent feature for this tumor. So carotid and cavernous sinus. identifying and stimulating the sixth nerve. This patient had a sixth nerve palsy pre-op, almost complete sixth nerve palsy, and I know now that she's 3 months post-op, and she has completely recovered her sixth nerve. Is back to normal. We're now using an angle scope, where you see we transected that pterygosphenoidal fissure, so I'm into the petrous apex, and I can drill all the way. This is the petroclaval fissure. You can see it very nicely. So this is claval bone here, petrous bone here, petroclaval fissure in between, and all these completely clean. I've drilled even with an extra margin to get a complete tumor resection beyond even tumor invasion. A patient like this, favorable pathology, usually I would not recommend radiation. Now, some tumors, if they go too lateral, they might be more difficult to access, only working through the nasal cavity. In this case, we developed at Pittsburgh, and this is a phenomenal idea about Dr. Carl Schneiderman, of going through the maxillary sinus in a contralateral fashion. Contralateral transmaxillary approach. Great design by Carl Schneiderman. And you compare it with the nasal approach, this gives you a better, much better angle of attack to the petrous apex. You are almost parallel to the petrous carotid in this direction. And this allows you to reach more posterior. And I've used this approach many times, and it's a great adjunct for selective cases. This one, for example, this patient had a previous orbitozygomatic approach for this chordoma, and all this tumor was left over in the cavernous sinus, in the posterior clinoids, dorsum sella, even next to the basilar artery and pons. And the patient was sent to radiation. And the radiation oncologist asked me if this is something we could resect. And I said, yes, of course, this is something we have to resect because, there's a lot of tumor left in there. So first step, you see a Vidian and pterygosphenoidal fissure. The carotid is being exposed right here. Pterygosphenoidal fissure as it goes up into the carotid canal in the foramen lacerum. This is the pterygoid tubercle right here. And then this is going to be Vidian right there. V2 is going to be lateral. And this is going to be where the lingual process is located. You can remove it if you want to get a bit more lateral exposure. And this gets you can see here, this is something called Vesalius vein, or a sphenoid emissary vein that I'm coagulating. And it goes just medial to foramen ovale for V3. Now removing the tumor here, and this is the very involved and abnormal Petrossal process of the sphenoid. The sixth nerve is going to be just above that, but this is full of tumor. So the sixth nerve presumably is going to be displaced. Now I'm going through the cavernous sinus. Opening the anterior wall of the cavernous sinus really well. You get significant venous bleeding, of course, but we use this hemostatic agent. I also use the trick of, simply reverse Trendelenburg to decrease venous pressure. That's very effective also. With this right angle knife, we open along the carotid canal. And I do that because I need to see the carotid to effectively remove this tumor. I do not like to just blindly aspirate tumor out. I like to see the carotid, and imagine this is a large piece of tumor that is the posterior clinoid heavily involved. I need to directly see the carotid when I'm doing this. And opening the contralateral cavernous sinus, same anatomy, inferior parasitical ligament, inferior hypophyseal artery, posterior clinoid is being mobilized, clearly involved dorsum sella here. And then this is completing all my bony resection. And now we're going to go intradural. And, oops, sorry. I wanted to move this a little bit forward for you. And then, so we're going to go intradural. I'm opening, and I'm working inside the cavernous sinus. I wanted to show you this using this transmaxillary approach. And then going to the maxillary sinus in a contralateral fashion, I can get deeper into the petrous apex. This is the sixth nerve up here. This is sixth nerve. And I'm working on removing all this petrous bone inferior to the sixth nerve that is so involved. This patient also had a sixth nerve palsy that completely recovered months after the operation. So we were able to get a clean resection of the petrous apex. And now this was really problematic because this tumor was severely attached to the brainstem, to the basilar artery and the bifurcation and the perforating branches. And this took me a lot of careful work to remove this tumor completely from the brainstem and basilar. And you see here the problematic situation when there's been another operation and there is significant additions. You know, the natural planes are not there anymore, so you have to find them. And here is dissecting the tumor carefully. You see two different perforating branches from the basilar. And as you know, you injure one of those, there is a significant risk of severe deficits, such as hemiparesis. But we were lucky with careful technique, we were able to completely remove this tumor. Even the dural attachment all the way lateral. And here what I saw was the anterior petroclinical ligament, the beginning of the tentorial edge. You're seeing it right here. This is the tentorial edge with the fourth nerve just behind. So we cut all the way to the tentorial edge. Superior, we cut the oculomotor triangle all the way until we see the pecum right here and the third nerve. When you cut this dura up here in the oculomotor triangle, the pecum can be at risk, so always be very careful with that. You see the third nerve running all the way to enter the cavernous sinus. So this is as extensive resection as I can make. All bone, all dura, all intradural tumor has been removed. And then we proceed with our multilayer reconstruction. You saw collagen, fascia lata, fat graft, and our septal flap. And this patient had an excellent outcome with no complications other than a sixth nerve palsy that recovered completely. But this shows how difficult these cases can be and how effective this resection was all the way in the petrous apex, all the way to the trigeminal nerve, all the way to... Thanks, Luke. So here is the post-op. You see the complete tumor resection. And with this, I like to bring the concept of supra-total resection because you want to get, if possible, extra margins, such as the newest low-grade glioma literature where they advocate for resection with margins when possible. In chordoma, I would advocate for the same. Whenever it's possible, let's get extra margins. Now, another example of a chondrosarcoma, young patient, 19-year-old, also coming from abroad with very large tumor. In this case, can we do all endonasal? And the answer is yes, you can do it all endonasal. You can see the beauty of this case growing through the petrocal fissure into the cavernous sinus and into the jugular foramen. And you can see here different sequences, a lot of tumor extending into the middle fossa, but this is going from inferior to superolateral. So you follow the tumor, you can actually remove it. This is another example of using a contralateral transmaxillary approach, so we can get to all that tumor. And this is the post-op with complete tumor resection. You can see all the tumor, the carotid preserved, petrous carotid, all the middle fossa tumor has been removed. And this is our happy patient. So just to finish the inferior petrocaval region, a few words on it. As we said, very difficult area, challenging. We described the anatomy of the, what we called at that point, the far medial approach, is the approach to the inferior third of the clivus that you extend more lateral into the jugular tubercle or the condyle and hypoglossal canal. As we said before, when we studied this, there was a significant learning curve when dealing with tumors in this area, complex anatomy. We studied carefully how to expand our approach more lateral, especially how to do a condylectomy. And I'm going to show you briefly this case of a nasopharyngeal, of a chordoma extending to the nasopharynx. When these tumors extend into the nasopharynx, they are sometimes embedded in the soft tissue and they are more difficult to deal with. And you need to be very careful not to leave residual tumor around. When they also extend intradurally in the lower clivus, those are, the most challenging one. And some of them, perhaps it's better to do a anterolateral approach or an extreme lateral approach better than an endonasal approach. In any case, we are seeing here how the median nerve is being dissected and transected, and I can follow it all the way back. Again, the pterygosphenoidal fissure is being found to take me to the foramen lacerum during the pterygoid. Again, there is tumor everywhere, but I need to find my landmarks. That is the corridor of the foramen lacerum, and I want to keep this as en bloc as possible. I want to work around the tumor as much as possible, not within the tumor. Only within the tumor once I have the outside very well delimited and the anatomy well lined up. Now I'm transecting the tumor from the pharyngobasilar fascia and from the nasopharynx. I'm finding a clean plane of dissection posteriorly. It's very important for us skull-based surgeons to be familiar and comfortable working in the nasopharynx. That's the pterygoid tubercle within the median and the pterygosphenoidal fissure, and then again finding my other carotid. Once I find my other carotid, I can transect the tumor from each pterygosphenoidal fissure. That is the upper limit. Both foramen lacerum are being exposed and transected, so I can detach the tumor. And this is working, transecting the nasopharyngeal tissues and deep to the tumor. That is C1 arch, that was foramen lacerum, foramen magnum, and then this tumor is removed en bloc for the most part. As I said, might look unusual for a neurosurgeon to work in the nasopharynx, but I truly think there is an area that we need to master when we do these exposures, so we can really know how to do a wide nasopharyngectomy. Know where to find the parapharyngeal carotid is always tricky, but we have some tricks for that. You see in this case, this tumor is embedding all the, there's a panclaval chordoma, so it's embedding all the bone here. This is the interdural extension, very limited in this case, but you see how I'm mobilizing the carotid artery and drilling all the bone that is next to it. And I can even move the carotid artery out of the canal. I use the bipolar coagulation to shrink carefully the venous plexus around the carotid so I can have a bit more space, so I can drill all the bone and remove it completely. This is one of the new instruments we designed to dissect the dura in an epidural fashion, and then taking the other carotid. So at the end, you are removing everything. There has to be no bone left. Again, I'm finding my Petrossal process, landmark for the sixth nerve, entrance into the cavernous sinus, down to the jugular tubercle, towards the petrous apex, and complete resection. So I'm not going to move it to the end because I see you part of this, and this shows you an example of. Okay, so some other examples. You know, these are, as we said, very challenging tumors going into the lower clivus. You can see here I did in Pittsburgh with a nice complete tumor resection, and the interdural portion of this tumor. If you want to play this video quickly, it's just a short clip showing if you remove all this tumor at the level of the jugular tubercle, you can end up seeing the lower cranial nerves. The video of this is you're coming from the front, so the lower cranial nerves are located posteriorly. The 12 is located inferiorly. That's the hypoglossal canal. This is the vertebral artery. This is the origin of the sixth nerve. Actually, sorry, it's not. It's up here. But these are the 9, 10, and 11 nerves going down. So ideal, and here we remove all the jugular tubercle, as this is showing here, to get access to this area. That's the benefit of doing these cases endonasally. And just to finalize, I think it's important to put a few words on reconstruction. Of course, we always worry about the morbidity of CSF leak, meningitis, etc. So we adopted this technique of multi-layer reconstruction. The first layer is a collagen that goes inlay. The second layer is a fascia lata that covers the clivus. The fat graft sort of buttresses this fascia lata graft on the clival recess, and then the flap on top. And then, very important, a lumbar drain. We like to keep it for about 3 days at 5 to 10 cc's an hour. Now, you would wonder about the lumbar drain, and this is something that has been always controversial and debated in the literature. So we use a lumbar drain or not after endonasal cases? So the answer is depending on the case. For example, in this particular case, this is a phenomenal study we did in Pittsburgh, and Paul Garner was the champion of this study for 2 or 3 years. We were randomizing patients in this study, so this is a very, very well done and valuable study. And we saw that we had to stop the study earlier because we were seeing already significant more leaks on the no lumbar drain group than on the lumbar drain group. But when we stratified our patients by location for posterior skull-based cases, mostly chordomas and some meningiomas, 50 patients we had, no lumbar drain, risk of CSF leak 30%, very high. With lumbar drain, 12%. And this was statistically significant. So definitely I would encourage all of you do these cases to use a lumbar drain post-op to decrease the risk of spinal fluid leakage. Now, these numbers have now gotten better because at the beginning we were not so consistently using multilayer reconstruction or extended flaps, and I think that makes a difference. We were not using ICG, as I'll show you. That also makes a difference. Now, what happens when the nasoorbital flap fails? And I'm sure many of you have had this occurrence, and this is really unfortunate, but it happens. A flap could be necrotic, or the flap maybe is transected, or simply there is no flap because you're doing a reoperation in a patient with no septum because someone else damaged it in a previous operation. So what are your other options? So I want to review these two with you. One is the inferior turbinate or lateral nasal wall flap, and that is a very important one. This is a flap that is pedicle of the inferior turbinate and of the lateral nasal wall. And it is so important to work with our ENT colleagues doing these cases because this is something they can do very well, and they really master this technique of raising these flaps as you see here. So let's go to the next, please, Luke. At the end, this flap, depending on how you raise it, the inferior turbinate is your conduit, and then the floor of the nasal cavity and part of the lateral wall can be your area for reconstruction. Sometimes it's not large, but regardless, it's very useful because it's providing vascular supply to your reconstruction. Here you see a fascia lata and then the inferior turbinate flap reaching this area. And this, in this case, was enough to solve these difficult problems of an inferior clival leak. Let's go to the next one, please. Now, an acrylic nasoorbital flap is something that is really problematic. Patients may present with meningitis and not necessarily a CSF leak. This is a patient with a very large meningioma I did, and unfortunately the flap was necrosed. The incidence is higher in patients with not good health, poor healing, etc. But in this case, the flap is clearly necrotic. You see, it's not well vascularized, it doesn't adhere. This patient developed meningitis without a CSF leak. And in those cases, it's not enough just to do antibiotics. This is dead tissue. You need to go there, you need to do debridement. And let's go to the next one, please. You need to do debridement, and then you need to develop another reconstruction technique. You can use a contralateral flap if you have it, but sometimes you don't have it. In this case, I use a temporoparietal fascia flap. This is something that I've done just a few times, thankfully, because it's like one of your last resorts. So in this case, what we're doing is we are working through the pterygopalatine fossa right here and coming from the inferiorbital fissure through the pterygopalatine fossa, we transpose this temporoparietal fascia flap. This flap is based on the STA and is the tissue that covers the surface of the temporalis muscle. By transposing it, you are bringing this large vascularized tissue into the nasal cavity. You can use this guide to this dilator to increase your corridor. And as you see here, we are now using again fascia lata and fat graft and all the same multi-layer reconstruction in the clivus. These are fat, but the key part is now bringing the vascularized tissue. Remember, this is a panclival defect, really large defect, and this is our temporoparietal fascia flap that we are bringing through the pterygopalatine fossa. This is in front of the pterygopalatine fossa right here. But this provides fantastic reconstruction highly vascularized tissue to the whole clivus, and this patient healed very well after this reconstruction. So if you're going to get into these complex cases, you need to learn how to have backup options to solve the many problems you can get into. So just to finalize, remember, endonasal endoscopic surgery is, in my opinion, the best approach for chordomas and chondrosarcomas in most cases, but not all of them. In our series in Pittsburgh, over the years with, over 200 cases or patients, about 15% of those would still require open approaches. And that's when this concept of the 6+1 skull-base approaches fits into it. I like this idea because, you have the one approach, which is the endonasal approach, that can access all these places. You can have endonasal approach to go from the anterior skull base all the way down to the craniocervical junction. But as tumors start getting lateral, endonasal approach might not be enough. Then you can use a combination of your orbitozygomatic approach, transpetrosal approaches, far lateral approaches to go to more lateral access if needed. So it's important as a skull base surgeon to combine both approaches, integrate into your armamentarium, and apply them wisely. This is, for example, transpetrosal approach. This is the classic Kawase approach, where you have the foramen spinosum. This is V3, and we are peeling the temporal lobe dura. We are finding the GSPN. I'm going to drill the petrous apex where all this tumor is located. Where in fact isolate the petrous carotid and remove tumor around it. You see that's your petrous apex, the estimated location of the internal acoustic canal, and your drilling. I'm going to skip this video. That's the GSPN. Actually, in this case, it's interesting because this GSPN, we had done an endonasal approach before, so the median nerve had been cut. So now we're cutting the GSPN, and this gives us better access to find first the tumor. We can mobilize V3 better, and then to drill the bone and expose the carotid. And here is going to require a complete skeletonization of the petrous carotid to remove the tumor around it. You see how we are using a diamond drill. The petrous carotid canal is being opened. We are dissecting it. And at the end, this anatomy is the same, open, same as endonasal. It's all about what route you prefer to use. A tumor goes very lateral, endonasal approach might be limited, and you might need to use a transpetrosal approach. Tumors like this is a recurrent giant chordoma, terrible case. You see this recurrent tumor here at the level of the jugular foramen. So how do you approach this? In this case, we chose to go one endonasal approach for this portion, stop at the level of the jugular foramen where the nerves are located, then come through a transpetrosal or transmastoid approach to get the remaining of the tumor. So two approaches for this patient, one endonasal and the other one transmastoid. And this, you can see endonasal approach this way, transmastoid approach this way. And you can combine approaches. They're not exclusive. They are complementary to achieve your goals. And as I said, often these patients with recurrent chordomas, chondrosarcomas that are involving the paravertebral space in this area. Can you do this endonasal? Maybe you can do some work endonasal, but it goes too lateral and it goes too posterior. And in this case, you might want to have better access using your extreme lateral approach, working between vertebral and carotid artery here. This is your corridor to get into the tumor, and working through your neck approach laterally. That's usually a better approach for these tumors extending to the paravertebral space. And you can see this mobilizing the vertebral artery, taking C1 and C2 masses. This patient will need a fusion, and will be able to work from C1 mass towards the midline, towards the odontic process, and achieve as complete resection as possible. The beauty of this is we are keeping all this approach extradural. If you have to remove the dura, you can. You can then just suture a patch, not often watertight, but you can bring your muscle flap to cover the reconstruction and use also fat graft that will really help preventing the risk of pseudomeningocele and CSF leakage. So I believe with this, we finalize our tour around chordomas and chondrosarcomas. This is a lot of surgical anatomy and nuances. As I told you at the beginning, I believe many of these are key and fundamental for making progress in improving our resection rates and decreasing the morbidity for these very complex cases. Go to the next one, please, Luke. So you saw this is a steep learning curve. Outcomes are definitely related to expertise. Experience of the surgical team is so important that these are treated as skull-based centers of excellence with high volume and large experience doing these cases. I review many of the multiple anatomical nuances that we have in this area, starting from the top. Posterior planetectomy through the cavernous sinus, Petrossal Process for the sixth nerve, Trans-Lacerum approaches to find the median nerve, Telegraph Tubercle fissure to get to the foramen lacerum, from there going down into the jugular foramen and jugular tubercle, up into the petrous apex. Of course, the important issues of reconstruction, remember always multi-layer, extended flap, lumbar drain usage is very important. And as a skull vision is so important to combine with transcavenous skull-based approaches when appropriate. I want to end up by thanking again Dr. Cohen-Gadol for his kindness, inviting me again, and his team. Luke, thank you for another wonderful webinar. Thank you.
You're welcome, Juan Carlos. Spectacular lecture, incredible expertise. Thank you for joining us. I really enjoyed it. A lot of learning pearls and a lot for us to learn from, including myself. So with that, I want to thank you again and look forward to seeing you in one of our future webinars. Thank you.
Thank you so much.